This is how ED leaders can leverage diverse teams to advance equity in care delivery and outcomes. I am Alina Kirkarina.
And I'm Turi Merman.
We have no disclosures to report. This lecture will provide emergency medicine leaders with an evidence-based and practical approach to addressing racial and ethnic disparities in the workplace. We will start by describing the current disparities in workforce representation and care delivery for patients in the ED. We will then discuss the impact of diverse teams on patient satisfaction and health outcomes, and present bias mitigation strategies for recruitment and retention of a diverse workforce. This lecture will conclude with care delivery and reporting outcomes. Each section incorporates recommended next steps for emergency department leaders committed to decreasing racial and ethnic disparities. It is now well recognized that diversity, equity, and inclusion within healthcare teams is vital for the care and well-being of patients, trainees, and practicing clinicians alike. However, physicians from diverse racial and ethnic backgrounds continue to be underrepresented in medicine. According to the 2022 Physician Specialty Data Report by the Association of American Medical Colleges, only 6.1% of emergency physicians identify as Hispanic, 4.9% identify as Black or African American, and 0.4% identify as American Indian or Native Alaskan. Despite 19.1% of Americans identifying as Hispanic, 13.6% identifying as Black or African American, and 1.3% as American Indian or Alaskan Native. A diverse and inclusive environment can improve patient outcomes and satisfaction, foster a better learning environment for trainees, and enhance care delivery within emergency departments. Racial and socioeconomic disparities persist in emergency department processes and outcome measures. Starting at triage, minority and low-income patients are more likely to be jumped in the triage queue, be placed in the hallway, and leave before being seen by a provider compared to white patients with the same acuity rating. Similarly, Black patients with undifferentiated abdominal pain are less likely to receive narcotic pain management than white patients. This disparity extends to pediatric emergency departments, as Black children with fractures are also less likely to receive opioid for optimal pain reduction compared to white children. Patients with limited English proficiency have higher rates of diagnostic testing, stress testing, and higher admission rates when returning to the ED within 7 days. Black male patients have lower odds of timely door-to-balloon care when presenting with an ST segment elevated myocardial infarction. A diverse workforce can expand access to high-quality and culturally sensitive care for racial, ethnic, and linguistic minorities, resulting in better patient outcomes. Prior research shows that racial and ethnic minority primary care physicians disproportionately serve a larger share of minority, low-income, and uninsured, and historically underserved patients. Furthermore, a recent study found that a 10% increase in the proportion of primary care physicians who identified as Black was associated with a 1.2% decrease in the all-cause mortality differences between Black and white patients. Patients treated by racially concordant physicians have previously reported higher satisfaction compared to patients treated by racially discordant physicians, further bolstering a diverse workforce as a means of offering patients greater choice for seeking care that is accessible and aligned with their preferences. Although similar research focusing on emergency medicine physicians has not been conducted, emergency medicine residents and recent graduates are not immune to racial bias. As very few emergency physicians identify as a racial or ethnic minority, recruitment of a diverse workforce can mitigate implicit bias and improve patient outcomes and department performance on key process and outcome measures. It is therefore important for emergency department leaders to invest in the development, recruitment, and retention of a diverse workforce. Development, recruitment, and retention of a diverse emergency medicine workforce needs to start early. In addition to the culture fit of the profession, students often cite acting internships, elective rotations, and core clerkships as having a strong predictive impact on their specialty and interests of choice. The emergency department leaders should work with clerkship directors to ensure an environment that prioritizes diversity, equity, and inclusion to mitigate assessment bias. Compared to preclinical years, clerkship grades are often perceived as more subjective and susceptible to bias. Racial bias has been documented in standardized assessments, including the emergency medicine standardized letter of evaluation, rank against peers, and grade portions. Historically, the training environment has not been conducive for minority students as they have faced implicit bias, microaggressions, and mistreatment throughout their training. The use of grading committees, expanding access to question banks, training on implicit bias for students and faculty, recruitment of diverse staff, and a commitment to ongoing quality improvement has been shown to minimize grading disparities for minority students during clinical rotations. Recruitment and retention of diverse faculty members is important for sealing the leaky pipeline of medical education, as students can benefit from mentorship, advising, and connection to opportunities. However, recruiting diverse faculty alone is not enough. Medical students pay attention to interactions between faculty members for cues regarding acceptable professional behavior. In one study, female students, minority students, and students who identified as lesbian, gay, or bisexual reported witnessing instances lacking in respect for diversity among faculty members. Such interactions, including inappropriate humor or discriminatory remarks, can directly impact the learning environment and students' subsequent performance on assessments. These issues also impact emergency medicine trainees, attendings, and faculty members. Junior emergency medicine residents often cite authenticity and representation as important factors in their evaluation of potential residency programs. Yet, less than half of emergency medicine training programs engage in at least 2 strategies aimed at recruiting a diverse class of residents. Racial disparities also persist in faculty promotions, as 7% of associate professors and less than 6% of full professors in emergency medicine are minorities. It is important to value the time spent by diverse team members, especially those from historically marginalized backgrounds, in improving care delivery for the department and hospital. Conventionally, such labor is delegated to service or volunteer work and not appropriately included in promotion advancement processes or granted adequate protected time and resources. Diverse teams can improve delivery of equitable care in the emergency department. Improvement of the training environment can increase workforce diversity, leading to improved patient outcomes and satisfaction. Similarly, shared experiences can foster empathy. Physicians from historically marginalized backgrounds may develop a higher emotional IQ from having to navigate difficult situations and discrimination on a regular basis. Different lived experiences support diversity of thought and innovation, which is not captured in existing standardized tests, and can exacerbate disparities in the physician workforce, but is increasingly important in the face of a growing healthcare provider burnout.
Ultimately, this is a framework of action that we propose, starting with defining diversity, equity, and inclusion metrics, which can include implementation of bias mitigation policies for clerkship grading, the portion of residency curricula time spent on reviewing racial disparities in emergency care, and the presence of bias reporting mechanisms. Additionally, we propose setting clear diversity, equity, and inclusion goals. So based on these metrics, setting specific and measurable DEI goals can help foster increasing the representation of underrepresented groups by a certain percentage over time, for instance. Fostering inclusive team culture is another important piece of this framework. Emergency department leaders who are committed to addressing these disparities in their departments should partner with colleagues at each step of the process, including clerkship directors, residency program directors, nursing leadership, social work, and case management, and ultimately leading to the ability to implement bias mitigation strategies. For example, a reporting dashboard can be shared with team members to yield actionable data, hold all accountable for supporting diverse teams, and improve care delivery in emergency departments. Significant work has already been done by minorities in medical leadership that can provide a template for how to tangibly increase diversity in workforce recruitment and retention, and subsequently improve equity and quality of care provided in the emergency department. Ultimately, the onus for providing equitable care should not remain on providers from historically marginalized backgrounds. We propose an adaptation of existing quality measure frameworks for ED leaders to use, with some examples below. Analogous to the White Coats for Black Lives Hospital Report Card, emergency department leaders can commit to collecting, monitoring, and reporting disparities data. These metrics can include, as mentioned, implementation of bias mitigation policies for clerkship grading. These reports can be paired then with performance on measures and processes known to have racial disparities that we discussed earlier, including queue jumps, hallway placement, departures against medical advice, pain management, and door to Maloon time. Ultimately, emergency department leaders need to partner with all colleagues in an interdisciplinary and interdepartmental format. One example of a roadmap that has been established is at Mount Sinai, where there's a clear intent to align priorities and define shared goals around DEI. Ultimately, by implementing a rigorous framework to advance equity, we can build diverse and inclusive teams where everyone thrives. Thank you.